Okay, let's unpack this. Today we're doing a deep dive into something absolutely crucial for newborn health and definitely high yield for your MSRA, Surfactant Deficient Lung Disease,
Mm-hmm.
or SDLD.
Mm-hmm.
You shared some incredibly detailed notes, and our mission really is to pull out the most important nuggets, to make sure you've got a rock-solid understanding.
Exactly. We're aiming to synthesize all that information into something really digestible and focused on what you absolutely need to recall for the exam.
Think of surfactant like dish soap for the tiny air sacs in the lungs, the alveoli.
That's a good analogy.
Yeah, if there's not enough of it, or maybe if it's not working properly, those sacs can collapse. Makes it incredibly hard for a newborn to breathe.
So we're going to explore what leads to this, who's most at risk, how it's recognized, and crucially, what can be done about it.
But we're covering the key areas, what SDLD actually is, the definition, right?
Right. Then why it happens, the etiology, who is more likely to develop it, those risk factors.
And what's going wrong at a lung level, the pathophysiology. Very important.
Definitely. Then what else? It could be the differentials, how common it is, the epidemiology, with a UK lens where we can.
How it presents those clinical features you'll see, how it's diagnosed, the investigations.
And of course, the treatment strategies management, what the future holds, so prognosis, and any potential longer-term issues, the complications.
Get ready for those hopefully light bulb moments that will not only help you understand SDLD, but also give you some practical ways to remember the critical details for your MSRA.
Okay, so definition first. At its core, surfactant deficient lung disease means, pretty simply, there is a lack of that vital lung surfactant, or what is present isn't functioning as it should.
So it's either a quantity or a quality issue.
Exactly.
And this broad term, it includes conditions like respiratory distress syndrome, RDS, which is a major concern, particularly in premature infants.
Right, that's the big one people often think of.
Yeah, but it also covers genetic disorders that interfere with the body's ability to produce or utilize surfactant effectively.
So SDLD is the overarching category, you could say, and RDS is a really significant example within it.
Okay.
Precisely. And the fundamental problem, the bottom line, is that without sufficient good quality surfactant, the lungs struggle to expand properly. We call that reduced compliance.
Ah.
And those tiny alveoli become unstable and prone to collapsing at the end of each breath.
Let's dive into the why then, the etiology. You said this varies.
It does. For premature babies, the most common reason is simply that their lungs are immature. They just haven't had enough time in the womb to develop a sufficient surfactant supply.
It's really a matter of timing in their development, isn't
No,
it?
absolutely. Then we have the genetic surfactant disorders. Now, in these cases, there are actual mutations in specific genes.
Right.
Genes that are crucial for the production or the processing or even the function of surfactant. So this is a problem at a more foundational genetic level rather than just a developmental delay.
So who is more at risk? You mentioned prematurity is the big one.
Definitely the biggest single risk factor. Remember that sort of window around 26 to 28 weeks gestation? That's a critical period because surfactant production really ramps up in the later stages of pregnancy.
Gestational age is absolutely key then.
It is. Also, infants born to mothers with diabetes have a higher incidence of SDLD.
Oh, interesting. Why is that?
Well, there are theories around factors like hyperinsulinemia in the fetus, which might potentially delay lung maturation.
Okay. And you mentioned C-sections.
Yeah, interestingly, cesarean sections performed before the onset of labor appear to increase the risk.
Before labor starts.
Yes.
Right.
It's thought that maybe the hormonal changes and even the physical stress of labor might actually trigger the release of surfactant in the baby's lungs.
Huh. That's fascinating. So the whole process of labor itself kind of preps the lungs.
It seems that way, yeah. The physiological cascade of labor seems to play a role. Perinatal asphyxia, a lack of oxygen around the time of birth, is another important factor. It can both contribute to and worsen SDLD.
And I remember reading, surprisingly, it's more common in male infants.
It is, yes. The exact reasons why aren't fully understood, but it's definitely an observed phenomenon.
And we can't forget the genetic predisposition.
No, absolutely not. These disorders can run in families, often following an autosomal recessive inheritance pattern.
Which means both parents typically need to carry the affected gene.
Right, that's right, for the baby to inherit the condition. And building on that, your notes also highlighted maternal diabetes again, elective C-section, and the fact that the second born of premature twins might be at higher risk.
The second twin, why would that be?
There's a hypothesis, just a theory really, that the first twin might experience more physiological stress during delivery, potentially leading to earlier lung maturation compared to the second twin.
Right. Okay. Makes sense. So pathophysiology, how does it all go wrong inside the lungs?
Okay, yeah, this is where it gets really interesting. Surfactant's main job is to drastically reduce the surface tension within the alveoli.
Like we said with the dish soap analogy, breaking the tension.
Exactly. Think of it like the difference between trying to blow up a dry balloon versus one that's slightly wet inside. It's much easier with less surface tension.
Yeah, much easier.
So without enough good surfactant, those tiny air sacs, the alveoli, have a really strong tendency to collapse at the end of expiration when the baby breathes out.
Imagine those little bubbles just wanting to stick together and deflate.
Precisely. This repeated collapse leads to a mismatch between the air that's getting into the alveoli ventilation and the blood flow around them to pick up oxygen perfusion.
Ah, the ventilation perfusion mismatch, the VQ mismatch.
That's the one. And it results in the baby not getting enough oxygen into their bloodstream, hypoxemia.
And this whole sequence, the lack of surfactant, the collapse, the poor gas exchange, the low oxygen.
It all manifests as respiratory distress. And if this isn't effectively managed, it can unfortunately lead to further complications down the line.
So when a newborn is having breathing difficulties, it's absolutely crucial to consider other potential causes. What else could be going on? What are the key differential diagnoses we need to keep in mind?
Good question. We definitely need to think about meconium aspiration syndrome.
Okay, where the baby inhales their first stool.
Yes, exactly. Before or during birth. That can cause lung inflammation and blockage. Neonatal pneumonia and infection in the lungs is another really important one to consider.
Right, infection's always on the list. What about structural problems?
Absolutely. Conditions like pulmonary hypoplasia, where the lungs haven't actually developed to their full size or complexity.
Underdeveloped lungs.
Yeah. And congenital diaphragmatic hernia, where abdominal organs push up into the chest cavity and compress the developing lungs. Those are also important to rule out.
Okay, so how common is SDLD? Can we get a sense of the epidemiology, particularly thinking about the UK context for the MSRA?
Yeah, getting precise UK-wide figures for all forms of SDLD can be a bit tricky. However, we know that respiratory distress syndrome, RDS, which is the most prevalent form, especially in premature infants,
That's the main one.
it affects a significant proportion, maybe around 15 to 20% of premature births. And that percentage is even higher in the really, really premature infants.
Wow, okay. And the genetic forms, you said they were rarer?
They are considered rare, yes. But it's important to remember that while they're uncommon, they can present in both preterm and term infants who develop significant respiratory distress, so you can't completely discount them.
Right, okay. So how does SDLD actually present clinically? What are the key signs and symptoms that should, raise suspicion?
Well, the clinical features really depend on the severity and, of course, the underlying cause. In premature babies with RDS, you'll typically see a cluster of signs indicating their struggle to breathe.
Such as? Give us the key indicators we should be looking for.
Okay, so you'll often observe tachypnea, that's rapid breathing, usually more than 60 breaths per minute.
Okay, fast breathing.
They may exhibit an expiratory grunt, it's a sound they make, trying to keep their airways open at the end of expiration.
Right, grunting.
Nasal flaring, where the nostrils widen with each breath. And chest wall retractions, you'll see the skin between their ribs and below their sternum pulling in sharply with each breath.
Working hard to breathe.
Exactly. And finally, cyanosis, that bluish discoloration of the skin and mucous membranes, which indicates low oxygen levels.
And how might the genetic surfactant disorders show up? Is it different?
It can be more variable. You might see really severe respiratory distress very early in life, sometimes even right at birth in term infants, which can be a clue.
Okay.
These babies may also experience recurrent lung infections and perhaps poor growth, what we call failure to thrive.
Okay, so how do doctors go about diagnosing SDLD? What investigations are most helpful here?
A chest x-ray is really a cornerstone of diagnosis for RDS.
Right, the x-ray.
In RDS, it often shows a characteristic ground glass appearance throughout the lungs. It looks kind of hazy.
Like frosted glass.
Yeah, exactly. As well as air bronchograms, where the air-filled bronchi stand out against the collapsed, hazy alveoli. It can also show reduced lung volumes, like the lungs look small.
Okay. What about blood work?
Blood tests are essential, partly to assess the baby's overall condition, but also to help rule out other causes of respiratory distress, like infection, sepsis screen, CRP.
Sure.
But arterial blood gas analysis is particularly important.
The ABG.
Yes, it provides crucial information about the baby's oxygen levels, carbon dioxide levels, and their blood pH. It gives a direct measure of how well their respiratory system is functioning.
And if a genetic cause is suspected based on the presentation or family history.
If there's a strong clinical suspicion for a genetic surfactant disorder, then genetic testing can be performed to look for specific gene mutations known to be associated with these conditions.
All right, we've potentially got a diagnosis. What's the management strategy? What are the key interventions for these babies?
Management really depends on the specific situation, especially whether it's RDS in a preterm infant or one of those genetic disorders.
Okay.
However, fundamental supportive care is always essential. Things like maintaining a stable body temperature, thermoregulation.
Keeping them warm.
Yeah, providing adequate hydration and nutrition, getting the basics right.
And the respiratory support. That seems key.
It is. Respiratory support is often necessary, and it can range from just supplemental oxygen delivered via nasal prongs
Trickle oxygen.
to more advanced techniques like continuous positive airway pressure CPAP, which helps keep the alveoli open, or even full mechanical ventilation through an endotracheal tube if they're really struggling.
And then there's the vital surfactant replacement therapy you mentioned.
Absolutely. Exogenous surfactant replacement therapy is, well, it's a life-saving treatment for RDS in premature infants. It's made a huge difference.
How does that work?
It involves directly administering surfactant, a manufactured or animal-derived version, into the baby's lungs, usually via an endotracheal tube.
Straight into the airway?
Yep. This helps to reduce that surface tension we talked about
Yep.
and improves lung function dramatically, often quite quickly. What about managing the genetic forms of SDLD? Is surfactant therapy used there?
Sometimes, but management for genetic surfactant disorders is often more about long-term support. It's less about a single cure.
Okay.
So this includes ensuring optimal nutrition, maybe providing ongoing respiratory support, which might include home oxygen or non-invasive ventilation, and aggressively treating any lung infections that crop up.
And in really tough cases.
In very severe refractory cases, lung transplantation might be considered as a last resort option. But that's obviously a major undertaking.
Yeah, of course. Now, your notes also highlighted something really important, giving corticosteroids to mothers at risk of preterm delivery.
Yes, absolutely crucial. Antenatal corticosteroids given to mothers who are likely to deliver prematurely are a key preventative measure.
How does that help?
These steroids cross the placenta and actually help to accelerate lung maturation in the fetus, boosting their own surfactant production. This significantly reduces both the incidence and the severity of RDS if the baby is born early.
So, a really important prenatal intervention.
Hugely important.
Okay, so just to quickly recap, the immediate treatments for RDS oxygen, assisted ventilation as needed, maybe CPAP or intubation,
Right.
and the timely administration of that exogenous surfactant directly into the trachea.
Precisely. Those are the critical immediate interventions for RDS in preterm infants. Get those right, and it makes a massive difference.
What's the long-term outlook for babies with SDLD? What can families expect in terms of prognosis?
Well, the prognosis is quite variable, as you might expect. For RDS in premature infants, with all the advances in neonatal care, the majority actually do very well and have a good long-term prognosis.
That's good news.
It is. However, it's important to remember that prematurity itself can have other associated risks, neurodevelopmental issues, and so on, separate from the RDS.
Sure, it's not just the lungs and the prognosis for the genetic disorders.
For genetic surfactant disorders, the prognosis is more heterogeneous, more varied. Some individuals may have milder forms and do relatively well with ongoing support, while others can have severe progressive lung disease with a much higher risk of morbidity and mortality, particularly in infancy and early childhood. It really depends on the specific gene and mutation.
Right. Finally, what are some of the potential complications associated with SDLD that we should be aware of, both short and long term?
Okay, so acute respiratory failure is a significant immediate complication, obviously.
The reason they need support in the first place.
Exactly. Babies with SDLD are also at increased risk for pulmonary infections like pneumonia.
Makes sense. Vulnerable lungs.
Yeah. And in premature infants who've had RDS, especially if they needed prolonged ventilation, chronic lung disease can develop. This is often known as bronchopulmonary dysplasia, or BPD.
BPD, okay, leading to long-term respiratory issues.
Yes, potentially needing oxygen or inhalers for months or even years.
And what about the cardiovascular system? Any knock-on effects there?
Pulmonary hypertension, which is high blood pressure in the lungs, can also occur as a consequence of chronic lung disease related to SDLD or BPD. And as we touched on, in premature infants in general, there's a recognized risk of neurodevelopmental impairment. This is multifactorial, not solely due to SDLD, but the severity of illness in the neonatal period can contribute.
What about long-term complications specifically related to the genetic forms? Are they different?
Yes, in genetic surfactant disorders, chronic respiratory insufficiency is a very common long-term complication. These individuals often require prolonged or sometimes even lifelong respiratory support, like oxygen or ventilation.
Okay, a significant long-term burden for those
It
families.
can be, yes.
So, to bring it all together for your MSRA prep, understanding surfactant deficient lung disease, particularly RDS in preterm infants, is pretty essential, wouldn't you say?
Absolutely. Remember the critical role of surfactant and that whole sequence of events when it's lacking that pathophysiology bit.
Focus on those key risk factors for RDS prematurity and maternal diabetes are prime examples. Remember those.
Right. Understand the pathophysiology. Think about the sticky alveoli and the resulting breathing difficulties. And definitely be familiar with the clinical presentation, the grunting, the retractions, and the game-changing impact of surfactant replacement therapy.
Yeah.
That's a key management point.
Keep that sticky balloon analogy in mind, maybe, for remembering the alveolar collapse. Hopefully this deep dive has provided you with a really clear and memorable overview of surfactant-deficient lung disease for your revision.
Yeah, hopefully distilled those notes down. And as you continue your preparation, maybe consider this. How are ongoing advancements in neonatal respiratory support, things like less invasive ventilation techniques and maybe newer surfactant therapies, further improving outcomes for these vulnerable newborns?
That's a great point. It's an area of continuous progress, isn't it?
It really is.
Absolutely. And for more fantastic high-yield resources to help you absolutely ace your MSRA pediatric module, make sure you check out PathMSRA.com.
And freemsra.com as well.
Yes, and freemsra.com. They are packed with invaluable materials, practice questions, and really everything you need to feel confident and succeed.